Okay, good morning, everyone. Happy Friday. You're in for not one, but two presentations today. We have Dr. Timothy Wilkin and Dr. Tom Martin presenting for us today. So welcome, everyone. I'm going to quickly introduce them because there's a lot to go over with. So Dr. Timothy Wilkin is Professor of Medicine and Chief of Division of Infectious Diseases and Global Public Health at UCSD. Dr. Wilkin is a clinical trials researcher with a focus on prevention of HPV-related cancers in people with HIV. His work includes clinical trials to define the role of HPV vaccination in people with HIV and its utility for prevention of oropharyngeal cancer. He's conducting trials on optimizing cervical cancer screening in low and middle-income countries. Dr. Wilkins has a long-standing research and clinical expertise in the prevention of anal cancer in at-risk populations. His work is funded by the National Cancer Institute, NIAID, ACTG, and AIDS Malignancy Consortium. And I'll introduce Tom as well, and that way we're done. Dr. Tom Martin is an assistant clinical professor at UCSD. He's an infectious diseases physician, providing HIV care at Owen Clinic and infectious diseases care at the VA. He has an interest in low barrier care and has recently published work looking at the use of machine learning to improve the identification of persons with HIV who are out of care and the use of long-acting injectable therapy in high-risk populations. He is also a site investigator with the AIDS Clinical Trial Group and is our token Brit on the clinical team, because we always need at least one of those. So team, please take it away, and I'll mute myself.
Okay, hopefully everyone can see the slides. Give me 1 second. Okay,
Perfect.
Great. So I'm talking today about HIV prevention as an update from the last CROI. There we go. So first abstract we'll talk about is a pillar study. I thought this was interesting because it was an attempt to a phase 4 study to roll out long-acting cabotegravir in 17 clinics. Just as a side note, the total participants 201. I think we have that many people on long-acting cab in Owen Clinic. But the rest of the country hasn't really figured out how to offer this on a large-scale basis. So this was an attempt to kind of roll out long-acting cabotegravir for prevention. So in this study, they enrolled mostly men who have sex with men and some transgender men as well. They noted that they enrolled 26% Black, about 40% Hispanics. The main thing that they were interested in was really how did people persist on the long-acting cab for prevention. And so that they've found that about 72% completed all the injections, I think through a year, and estimated that 6-month persistence was 85%, 73% at a year. They noted that there were no HIV acquisitions, but there were a fair number of sexually transmitted infections, indicating that people remained at risk while they were receiving the long-acting cabotegravir. While this prevention has a great promise, especially in certain populations, including young Black men who have sex with men, there's still a challenge with just how to roll that out effectively. The next study to talk about HPTN 094. I know Laramie was heavily involved with this trial, and I think she's spoken previously about the work that she's done with this. But HPTN 094 is a study that was looking at peer health navigation with or without mobile services for people who inject drugs. So the idea was to improve substance use treatment access, PrEP access, and overall outcomes for people who use drugs by bringing services directly to the population. So it was a very interesting study in how they set up specific sites, specific neighborhoods, and really where they chose to provide the clinical trial or conduct the clinical trial. So for this study, they randomized about 450 people to either an active control of just pure health navigation alone, or the active group of health navigation plus mobile unit services. And their endpoint was at 26 weeks to see who was accessing medical assisted treatment for substance use, viral suppression for people living with HIV, PrEP use for people without HIV, as well as overall mortality and some other outcomes. So they did enroll mostly people without HIV, about a little less than 10% with HIV. Housing was a huge challenge with only around 20 to 30% having a residence, and others having either being unhoused or in very transitional housing. They did have a pretty spectacular follow-up of over 85%, which is quite high given all of the challenges in this group. So their primary outcomes, they looked at whether they were using the medication for substance use by actual biomarkers, so the presence of the drug and prescription data, and they found pretty low uptake across the arms, and no difference really between arms, around 7% taking up these therapies. When they asked self-report of use of these therapies, it was much higher. And then of note, for a relatively small sample size, but among people living with HIV, only about 40% were virally suppressed, and low uptake of PrEP in the other group. There was one HIV acquisition in both of the arms in people without HIV. What I think was really drew the most attention was the overall mortality. So really a very large death rate among the people in the study. So among the active controls, there was a death rate of about almost 10 per 100 patient years, which is quite high. And they saw a marked but not statistically significant reduction in mortality in the intervention arm. When I viewed the presentation, they didn't discuss exactly the mechanism of this, so I don't know if others on the call know, but I assume it was provision of naloxone and other harm reduction approaches that greater uptake in the ones that had the mobile services, where these interventions were brought directly to the population. So I think a very promising result, and supports a lot of the work that we do here in the division to bring these therapies to people who use substances to reduce overall mortality and improve outcomes. Next, there's a study about HB10084. I had to watch this a couple of times to totally understand, but basically this is a study of long-acting cabotegravir in women in sub-Saharan Africa. And so as people recall, the study was markedly successful, showed the benefit of long-acting cabotegravir over FTC TDF in this population. This presentation is from the open label extension, where women were given a choice to either which product basically to continue, and most women chose to continue or to choose long-acting cabotegravir. So this study looked at really HIV testing in this circumstance. There is recommendations for the RNA testing in addition to the antibody antigen testing. And there are some issues with really actually being able to determine who's living with HIV and who's not. So what they did was they looked at all of the positive tests that they had among the participants in the open label study. They were able to confirm HIV tests or HIV infection in 8 participants. And 4 of them, it start basically with an isolated viral load positive. And then 4 of them had other tests that were initially positive. But what we want to focus on are the false positive tests. So uh, there were 87 participants who had 1 or more reactive tests that did not have HIV confirmed. And so, and among these, 12 of them had an isolated RNA positive test where they could not confirm the infection. And some of them had CAB. Most of them had CAB recently, but some of them had their last injection of CAB over 6 months ago. And the so the concern was that the false positives uh, RNA test led to delays of injection to over 10 weeks, putting women at risk for acquiring HIV when in fact they didn't have HIV in the first place. I think the other tests were positive might have been just false positives on the antibody antigen tests. So overall, the single HIV RNA test performance, they said had a false positive rate of 75%. So only 1 out of 4 women in this situation were actually living with HIV. And so they noted caution about using these tests. I don't think there was exactly a solution for for how to do the testing. I think another slide that wasn't included was looking at the viral load testing. So the positive predictive value, I think, goes up as the viral load goes up. So if you have a test that's like 1,000, you can feel confident that that's what's going on. But if you have test results that are RNA detected, but below the limit of quantification, or even low level, less than 100 viral or less than 100 viral loads, that's when you would be concerned that there would be more of a false positive. So I don't know if this comes up often in ON with people on this therapy, but definitely in this large clinical trial, not an uncommon phenomenon. There was also a presentation about outcomes after HIV treatment. I don't think there's probably much use in, outcomes of HIV treatment after acquiring HIV while receiving long-acting cabotegravir. Um, the numbers are relatively small. There seem to be basically reasonable viral suppression rates. That there was 1 person that was successfully treated with an INSTI, I guess had just minor, maybe cabotegravir mutations. Basically, there's not a whole lot of data of how to treat this, but the author suggested that there needs to be more data to guide the choice of optimal regimens in this situation. But I think we do have lots of options beyond integrase inhibitors to treat people who require HIV while receiving CAB. Okay, so some interesting future prevention therapies. Just briefly, they presented an analysis of lenacapavir. As people know, then the purpose studies, 100% effective for HIV prevention. They presented data on a small number of adolescent girls that were in the trial. I think only thing really to say is there are no infections in any of the groups and relatively small numbers of these girls enrolled, but they did note that the safety was reasonable, that there were no discontinuations of lenacapavir in this group. And oops, I don't know if you're seeing that now. Okay. Okay, and then they also looked at the trough concentrations, and it was similar between adolescents and adults, providing some reassurance if you choose to use lenacapavir in this group. So we have the option of on-demand PrEP and great clinical trial data for men who have sex with men. We don't have any clinical trial data that I'm aware of for women, cisgender women. And as we know from prior studies of TDF-FTC PrEP for women, there's a different adherence standard that's required for women to get the benefits of PrEP. So if you're dosing daily, they really should be taking 6 or 7 doses a week, nearly perfect adherence to get the maximal benefit. Whereas for men, probably 4 doses a week or more is adequate. So this was not a clinical trial. This was a pharmacokinetic modeling study where they modeled different dosing of PrEP, potential on-demand PrEP regimens to see how the target concentrations would be, how sustained the target concentrations would be for really getting the maximal protection for on-demand PrEP in uh, cisgender women. So they looked at a few different dosing strategies, the 2-1-1, which is the standard dose that we use for men, 2-2-1, 2-2-2, and you can see there were four-day dosings as well that were modeled to see how long these protective concentrations would be maintained. And so what they found here on the graph, if you look at the far left, this gray line, you can see the concentrations drop down, and really the protection, the ideal concentrations are only really maintained for 4 days. So with any of these strategies, you do get an extension of protection out through 7 days, which seems to be probably more desirable for the a more desirable PK outcome for this type of regimen. And so they noted that there were several different regimens that kind of provided this protection, and they suggested, in conclusion, a 2-1-1-1 really being considered for further investigations, perhaps even clinical trials. So if I don't know that anyone's really recommending this therapy, but if for some reason that is the approach that's chosen for cisgender women, you definitely would, based on these data, add a 4th day of dosing to really get more sustained PK protection. The other modalities for PrEP being investigated, there was analysis of daily oral FTC TAF overall that didn't do well, but like other TDF FTC studies in women, it was really related to adherence. And so based on concentrations and data, similar analyses that they've done for all of the prior studies of TDF FTC PrEP in women, it suggested that it was effective if the adherence was maintained at a high level. There was also a presentation on a multi-prevention technology of injectable cabotegravir with medroxyprogesterone acetate implant, which is exciting to give more protection against pregnancy as well as HIV. And then a super exciting study about once yearly intramuscular lenacapavir. So this was quite a large injection. It was 5 ml doses, 2 5 ml doses, and it was actually well tolerated. There weren't the nodules that you get. There was some injection site reactions and pain, but really not anything remarkable from what I could see. And they kind of overshot the PK, so the after a year was still like really high levels. But their next study will be based on that, they picked a dose that they'll be using for yearly lenacapavir for HIV prevention. It's a big study, so we should really try to get on board for those studies. But that would be an incredibly exciting technology. And there's also a once monthly NRTTI that was presented so once monthly oral NRTTI in a macaque model, so that could enter clinical trials in people as well. Just briefly about STIs and other preventive strategies. Mpox, I presented the results of the randomized arms for tecovirimat. I'll be talking about this in Medicine Grand Rounds in a couple of weeks, so maybe we'll skip past that. Short answer is it didn't work. When we looked at clinical resolution, pain, a number of outcomes. We also looked at uh, clearance of virus. There wasn't anything really marked to support tecovirimat. So we need to continue looking for other therapies for Mpox. I think I want to skip ahead just so I give Tom enough time. The Just additional data out of San Francisco for the use of doxycycline for post-exposure prophylaxis. They did another detailed analysis that basically showed that the people who received doxypep basically had a much lower incidence of STIs than they did prior to receiving doxypep. And so and just additional real world data that's is showing like a population level impact of doxycycline post-exposure prophylaxis as that really gains more momentum and is used more widely. And then lastly, hepatitis B and other STI, there were data from the ACTG about the use of the alternative, I'm forgetting the name of it, Hepcera, I think is the name of the alternative hepatitis B vaccination. So what they had shown is that for people who had previously not responded to hepatitis B vaccination, they got really terrific responses with this alternative hepatitis B vaccine. And more importantly, with a 3-dose regimen, this protective titers were maintained out through 72 weeks in nearly everyone. So this is a pretty common thing that we see in the clinic of people who have not responded to hepatitis B vaccination. On a side note, that's me. For some reason, I just never really responded to hepatitis B vaccination, but did get some response to this Hepcera. So definitely something to keep in mind in the clinic, and probably more effective hepatitis B vaccination to just use at the outset with higher seroconversion rates, especially among people with HIV. So really a vaccine to keep in mind. And that's just the graph that shows it's supposed to control of a high dose of the standard vaccine. You get much higher long-term protection with the Hepcera vaccine. Okay, so I will stop there. Any questions on this? Let's see if the chat.
There was one question from Eddie Saville. I think it was the study where they had measured RNA. He said, any thoughts that the low level of virus was due to recent exposure rather than infection?
Ooh, I don't think so. I don't know of any situations where the only thing that you can get with recent exposure is sometimes there can be local immune responses to HIV in the genital tract if you've been exposed to HIV. So that's been seen in some PrEP studies, but I'm not aware of any like little blips of RNA in very early infection that's then kind of aborted and doesn't establish a chronic infection. I'm not aware that that happens at all.
Thank you. And there's been a bit of a misunderstanding because both you and Tom did prevention. We thought, or Tom thought you were doing therapeutics.
Okay, you give me 1 minute. I have the slides for therapeutics. I reviewed it for IS USA. And Tom, you can pull out the email to condemn me for messing that up. If you just give me talk amongst yourselves, I'm going to go off camera for 1 second and I'll pull up those slides.
Tim,
Gabriel says,
not all of our slides overlap, so I have some.
Yeah,
Why don't you do a
stuff.
couple and then I'll fill out at the end.
Yeah,
Okay.
that's what I suggested. That and if there's stuff that Tim didn't mention from the massive studies, go for it, Tom, and then that gives Tim time to get the therapeutic slide, and so it means that you get 3 presentations instead of 2. So big day today, a bargain.
Can you see the slide? Okay.
Yep.
And so this has been a comical, epic failure, and we hope we have given everyone a bit of brightness in dark times. But here is how I took HIV prevention at CROI 2025, and there is some overlap, and I've actually sort of dulled out a lot of slides that I thought were that Tim covered, and I've kept some in where I had a bit more detail. So. For me, I thought there was several themes. There were new drugs on the horizon for prevention. There was diagnosing and treating HIV in the setting of long-acting PrEP, which I think Tim covered lovely. And then the use and rollout of PrEP, just some real-world data about how long-acting PrEP is being used, epidemiology of usage of PrEP, and then I had a few other things, so improved testing strategies, vaccines, a PEP, and mother-to-child transmission. So, starting with new drugs, Tim did show this, and this long-acting lenacapavir formulation looks really exciting. And so I just wanted to show you some of the pharmacokinetic data, and you can see that it has this peak that is about 3-fold the every 6-month dosing, and really both formulations had this sort of nice pharmacokinetic pattern, and I thought that was a super exciting. I just wanted to show you those extra slides there. And then in terms of adverse events, Tim did mention the pain, but there was one grade 3 adverse event, which was someone had syncope after they were given the injection. They were in so much pain, but I thought that was really promising. And this is the data that showed that icing seemed to improve some of the pain associated with the injection. Tim also very briefly mentioned this one, but I was quite excited by the formulation of this multi-purpose implant with cabotegravir and medroxyprogesterone. And so what it is the implant is a biodegradable copolymer that undergoes this phase inversion after you inject it, and then it gets slow degradation under the skin. And I thought some of the pharmacokinetics of this were quite clever as well. So this was the suppression of ovulation slide, which showed you had these very stable concentrations of medroxyprogesterone, but then the dotted blue line indicates that when they remove it, you get very rapid drop off of concentrations and return to ovulation in these macaques. And then this was the cabotegravir concentrations over time, which again sort of hovered so beautifully around the 4-fold protein adjusted IC at 90, and again drops off very quickly when you want to discontinue the implant and it's removed surgically. So I thought the potential for this in areas like sub-Saharan Africa was absolutely massive. So I agree with Tim that was a very important one. Okay, one thing that wasn't mentioned, I did find this poster that was looking at long-acting dolutegravir development, and this study from the University of Nebraska extended that prior work, looking at a formulation of long-acting dolutegravir, and they had improved their previous work by forming this homodimer ester of dolutegravir, and they were able to produce therapeutic levels that lasted for 4 months after a single dose. And so there's more long-acting formulations in the pipeline, and I was quite hopeful that this will eventually drive prices down and make them more accessible. So unfortunately, Tim really covered diagnosing and treating HIV in the setting of long-acting PrEP, and that was the HIV RNA screening, which I thought was fascinating. If you have a positive predictive value of just 20%, if the only positive test is the RNA, I thought that was really fascinating. And probably you made the best choice, Tim, about not really going over Dr. Landowitz's slides about HIV treatment outcomes, because they were very complex, and the summary was that probably just integrase inhibitor-based regimens after failing long-acting cabotegravir can be considered, but with careful monitoring. So I'm going to move right on to some data about the PrEP usage and rollout. And I apologize, I was in a kind of panic when I think Tim mentioned some of these studies, but I just had to show them again in case they weren't quite clear. So this was an observational study looking at CAB-LA uptake for PrEP across the Kaiser network in Northern California and Mid-Atlantic states. And so this represented about 5 million health plan members, and they looked at their, CAB-LA uptake in their population from using their electronic health records. And as you can see, since 2022, there's been a pretty steady increase across areas, mostly in the Northern California compared to the Mid-Atlantic states of long-acting cabotegravir. But these were data up till mid-2024. But I don't know, my overall impression was that 180 users across a population of 5 million seemed fairly low. From those 180, they did start on CAB-LA. There were 890 injections, and they reported that only about 10% were administered later than their due date, which seemed pretty good. And then after 1 year, they found that about a quarter of people had discontinued long-acting PrEP, although they didn't go into sort of great details about the reasons for those discontinuations. And then they had 0 incident infections during their follow-up for people on that. And then I think, Tim, you did mention this pillar study. And so this was an implementation study looking at CAB-LA rollout, comparing a routine CAB-LA implementation with a dynamic implementation. They didn't really go into those sort of comparison arms, but they did report some of their outcomes. And so the main results presented were that they had about 200 participants, and of those, about 3/4, again, so very similar to the Kaiser study, remained on CAB-LA by month 12, and that they had also no cases of HIV acquisition, which is obviously great news. The therapy was generally well tolerated. 5% of participants did experience adverse events significant enough to discontinue therapy, and those were mostly for injection site pain, as you would probably expect. And they concluded it was highly effective in real-world setting, and persistence on prevention was higher than seen with oral PrEP. They compared some historical data there in the discussion where they said oral PrEP continuation at month 12 was about 56%. Just briefly, this was a study looking at effective protective concentrations of CAB-LA. Please ignore the red circle. I accidentally screenshotted the wrong slide from their presentation. But this was a study using data from HPTN 083 looking at the minimum plasma CAB level during what retrospectively was thought to be the window that participants acquired HIV. And then they performed a case control study to look at the relative risk reduction depending on the minimum plasma CAB level during that HIV acquisition window. And as you can see, in the majority of cases of HIV, 64% were among people who had had minimum concentrations less than the 1 times adjusted IC90, whereas those with concentrations of 4-fold or more above the PA IC90, the risk reduction is much higher. So that just is supportive evidence that this sort of theoretical or sort of like animal model protective level of 4-fold times the protein adjusted IC90 is probably the right place. So this was a poster from a Dutch group, and I think these are just really sort of preliminary data, and there's more interesting things to come out of this study in the future, I suspect. But the study evaluated the impact of reduced frequency monitoring of oral HIV PrEP on the risky unprotected sex, and they were comparing online and every 6-month monitoring, and they found they were non-inferior with these specific outcomes to standard of care every 3-month monitoring. But just to note that I'm presuming they're collecting the data, but in this poster they did not comment on rates of HIV seroconversion or diagnosis of STI, and so I don't think that you can draw the conclusion which their title states that it's non-inferior to standard of care. But I do think that people worry about risky behavior if you're not seeing people so frequently, and I think this was they're trying to build evidence that you can make oral PrEP more convenient for people in certain settings. So this poster was presented from Monica Gandhi's group. And so it's a pilot RCT with about 50 participants up in UCSF, and it builds on their usage of urine tenofovir drug levels. And what they did was they used a motivational interviewing remotely administered to provide feedback on the urine tenofovir levels. And then overall, this randomized study found that the intervention resulted in a 1 to 2 tablet per week increase in PrEP adherence, as estimated by their hair tenofovir levels, which I thought was, one of the most promising outcomes from, their urine tenofovir level tools. The poster, unfortunately, didn't clearly indicate to me what the standard of care comparator was and whether you also used motivational interviewing without urine tenofovir levels, or whether it was just sort of standard PrEP care. But, I think that's a meaningful change, a couple of tablets a week in terms of protection. And so I thought this was a promising use. All right. I had some PrEP epidemiology slides, which I'll go over as well. And so this was an interesting poster that I found. It was about and it said that young people under 25 in the US now account for 20% of new infections, and that was in 2023. And this study looked at PrEP prescription among 13 to 21s with an indication for PrEP, and that was, diagnosis of an STI or a diagnostic code for high-risk behavior using commercial market scan claims data. Principal outcomes from the study authors were that females were less likely to receive appropriate PrEP, and there were quite wide geographic disparities with lower prescription rates in the Midwest and South. And I thought that fill rates were good in general among high-risk MSM, and I think that was somewhere around 40%. But the rates were quite low for patients diagnosed with syphilis. Also, it was notable that substance use was inversely correlated with PrEP prescription, and perhaps, that should really be the reverse. And then this was a sort of similar study from the CDC, which looked at PrEP prescription among adolescents and young adults using IQVIA real-world prescription data. And they found that prescriptions for PrEP among 13 to 19-year-olds and 20 to 24-year-olds is increasing across the country, including a small number receiving CAB-LA. And so while it's not perfect, things are probably improving in terms of protecting younger people, which I thought was good news, and also one of the few posters that the CDC was able to present. This was a poster from Washington State Department of Public Health that I thought looked quite interesting, and it looked at HIV acquisition within 3 years after Department of Corrections release by matching records with EHAR's database and stratifying groups to look at risk factors. They found that the rate of HIV acquisition for people with drug offenses and less than high school education was quite high, about 200 per 100,000 person years. In particular, they also flagged psychosis and other mental health disorders, education level, drug domestic violence, and property offenses as related to HIV outcomes. And so I love the way they linked these databases, and I think this would be, a really good reason to sort of highlight people who should be linked to, PrEP provision when they are released from Department of Corrections. There was one slide I had on improved testing. This was presented by the CDC as well, and this was regarding the Together Take Me Home program, which is a mail delivery HIV self-test program. And they were trying to evaluate the likely met needs across all 50 states of this program, trying to address the fact that 50% of US adults with elevated HIV risk have never had an HIV test. And so they had approximately 500,000 mailed tests, and it accounted for up to 20% of the testing needs in some states. And the low estimate was in Wyoming with just 2 to 4% of met needs, and the high was in DC, where the mail order program met probably 21 to 39% of testing needs. And so this really showed to me that mail order programs can sort of some of the unmet need for HIV testing across the States. And so I was pretty impressed with some of their outcomes there. There was a lot of vaccine work in terms of therapeutic vaccines, but not so much in the field of prevention. And so just to mention a couple, this was a study looking at the effect of a prime boost vaccination strategy using some mixed adjuvanted envelope-derived immunogen vaccines on the production of VRC01, broadly neutralizing antibody. And they found that their prime boost vaccination strategy compared to just a regular vaccination strategy was much better at inducing, and this, I should say, this is a 3 vaccination with 3 slightly different envelope vaccines. They were able to introduce neutralizing antibody levels to 20% of their tested panel of viruses, but this is mice studies. This vaccine study was, and I'm sorry they didn't upload their e-poster, so I wasn't able to get much of their data, but it was interesting. So this was a previously reported vaccination and published in Nature, where they produced virus-like particles constructed by the use of an mRNA vaccine. And it was previously demonstrated to prevent simian HIV in animal models. And here they report that inclusion of a protease protein in the vaccine combined with a full-length OMV-GAG induced improved protection from simian HIV infection. And so they're looking at sort of developing and working on the components of these mRNA vaccines to maximize protection, which I thought was quite exciting. Just a couple more, and then I'll hand back over to you, Tim. So there was one poster on PEP, which I thought was quite interesting. It was a modeling study, though, and it was incorporating pharmacokinetics, pharmacodynamics, and viral dynamics, looking at the usage of PEP, but in the setting of on-demand PrEP. And, you know, I had to read the poster through a few times. I'm not going to go through it in great detail, but I had a couple of big takeaways. First is regarding the time frame for giving PEP. We always think of it as being like a 72-hour. But if the person has been receiving on-demand PrEP and completed a course in the prior 7 days, it might still be worth using PEP. And so I just wanted to build in some flexibilities into people's mindset about the risk of acquisition if people have been on PrEP in the recent past. The second was a consideration that a person can self-start PEP if they've had an unexpected exposure, if they have PrEP at home. And then in this structure, you know, they saw quite significant reductions in risk if a person started their TDF-FTC as soon as possible if exposed, and then add a third drug as soon as possible. And this strategy might mitigate some delays in seeking care, which can result from travel, emergency department wait times, or lack of access to expertise and things like that. So that was quite interesting, insights there, but complicated to implement, I think. And then just finally, this was my sort of good news slide. It's data from South Africa, and it's been heartening to see that their data from 2011 through to 2020 showed very dramatic reductions in mother-to-child transmission, but there are still around 2% of children born to mothers with HIV who acquire HIV by age 2. So there is still work to be done, and it seems to have plateaued in the past 3 or 4 years at about that level. And so with that, I will end this car crash and back over to Tim for his second presentation of the morning.
That was a beautiful coverage of prevention in American and British accents. That's how we roll here. While Tim puts his slides up, there was a question for you, Tom, from Susan. Did they look at advertising outreach for PrEP across the country to consider met need relative to possible public awareness?
They didn't really, I don't think they addressed that question. They were just reporting, what their met needs were. But I think that the mail, I don't know is the answer, I'm afraid, Susan.
No worries, thank you.
Okay, we're ready for therapeutics, team.
Okay, the basic point is there wasn't a whole lot of therapeutics at the time. Is not a problem. So there were 2 clinical trials presented on doravirine islatravir So islatravir is the NRTTI, the translocation uh, nucleoside reverse transcriptase translocation inhibitor. So you may remember the development of islatravir was stopped at one point or paused at one point because of lymphopenia, causing lymphopenia that seemed to be a buildup of the islatravir inside the PBMCs causing that. So they've changed the dosing around and have restarted the program change with a reduced dose, and this is the the phase 3 daily dosing with doravirine, the 2 clinical trials. So both of these were switch studies. One of them was switching from bictegravir FTC TAF to doravirine islatravir, or staying on bictegravir FTC TAF, and the other one was a whole host of oral ART, either staying on that or switching to doravirine islatravir. And in both studies, there was very low rates in both arms of having detectable HIV RNA or HIV RNA over 50 copies per mil, according to the FDA snapshot regimen at week 48. And in both studies, there was non-inferiority of doravirine islatravir to the comparator arm. Importantly, there was no treatment emergent resistance to either compound doravirine or islatravir in either study. One thing, they looked very carefully at the CD4 counts and the lymphocyte counts, and there was no difference between the arms. So their reduced dosing of islatravir was successful. They've overcome the issue with lymphopenia. The one thing I don't, okay, it's on here that uh, there, it was interesting. There was investigation into HBV reactivation. So like cabrilpivirine or other non-tenofovir containing regimens, there's the issue of hepatitis B. So no one with chronic hepatitis B was enrolled into the study, but there were people that had prior hepatitis B or had a positive core antibody, but a negative surface antigen that were enrolled. And they did find some low-level viremia, uh, according to HBV DNA, but without surface antigen that occurred just a few cases in the study, but something to keep in mind. Now, there were cases of acute hepatitis B infection, presumably in people that did not have prior vaccination or protective antibodies. So it does highlight the need to, if you're going to use these non-tenofovir containing regimens, to really make sure that the people are protected against hepatitis B infection, and to keep in mind that even if they didn't have chronic hepatitis or active hepatitis B at the time, that reactivation is possible in these non-tenofovir containing regimens. They also looked at weight changes, and really nothing very new, that it didn't seem to be protective against um, uh, it didn't seem to lead to weight loss as compared to continuing the bictegravir. So we'll see some of the other studies about switching off of integrases and weight gain, but this did not provide evidence for that. There was a study of lenacapavir, as you know, given every 6 months, and then with 2 broadly neutralizing antibodies, TAB and ZAB, I'll call them, the short name. So this is, again, a switch study where people were randomized to either stay on their oral regimen or switch over to this long-acting injectable regimen. And their primary endpoint was having detectable or HIV RNA over 50 copies at week 26. And what they found was that was really quite successful. There was one person who had HIV RNA over 50 copies at week 26, compared to none in the people who continued their oral baseline ART. And then there were some interesting results. One thing that I don't think is discussed on the slide is that there was screening for susceptibility to these antibodies, and people were required to be susceptible to both antibodies. So over half of people who enter the study were not eligible for the randomization because they had pre-existing non-susceptibility to the antibodies. So this really, if it's rolled out on a larger scale, really only applies to a small or to a subset of individuals. And they did have anti-drug antibodies that emerged against both of the antibodies. However, it didn't seem to affect safety or pharmacokinetics or efficacy. But would they, in the future, if this were administered for years, would these antibodies become a problem? It's hard to say. And then again, one person developed resistance, and they did have loss of ZAB susceptibility and emergence of lenacapavir resistance. So pretty good results. I'm curious to see whether this will actually be pursued on a larger scale, given that there are other long-acting drugs with very long dosing intervals that are being developed. It's not clear whether this will be a strategy that's rolled out, but promising results. There was also a study from ViiV about intramuscular CAB given with N6LS, a broadly neutralizing antibody that targets the CD4 binding site. And again, people with stable viral suppression randomized to one of two dosing schemes for the antibody given with cabotegravir compared to oral ART. And what they found was that there were about 4 to 6% in the two arms that had viral load over 50 copies at week 26. I won't go into it, but there seem to be more reactions with the subcutaneous group, so they will be, I think, pursuing the IV group. I am just very curious why they're moving forward with this. I think this 4 to 4% is really high, and this would not meet non-inferiority definitions. I don't think they'll be able to establish non-inferiority with this regimen. So I'm curious why they're moving forward with it, given they have other options besides the N6LS. But I think there is a second part of the study, a larger part, where they're using this IV dosing with cabotegravir compared to continued oral ART. And then a little bit, I think there's a couple really promising drugs that hopefully we can figure out how to get on the bandwagon to participate in some of these trials. But there's a third generation INSTI, VH184, and it has in vitro activity against isolates that are highly resistant to dolutegravir and cabotegravir. And so in this study, it was they used an oral version of this, but they are developing long-acting injections. So this is a proof of concept with an oral version of the drug that will support the development of the long-acting injection. But they found just with the dose ranging studies, they found that it led to a 2-log decrease in HIV RNA and people who had not been previously treated with antiretrovirals without serious adverse events. So had nice PK/PD relationships, so that they're able to identify some target concentrations that they want to achieve with the injection. And so that will be interesting to see how that's paired with other regimens for kind of next generation long-acting regimens. They had a very similar study, but with an HIV-1 capsid inhibitor, so similar to lenacapavir, again, oral dosing, and they found that, again, good virologic decay with the dosing. So they had, again, a dose-response relationship and can pick the target concentrations for future studies. I believe this is also planned to be an injection, a long-acting injection as well. And so, they're side by side here. You could imagine that if they can have long dosing intervals of every few months or every 6 months, I think we could easily see studies of these two combinations together. So really exciting long-acting technologies, and This is V, but I think this same product profiles exist at Gilead. They already have the long-acting capsid inhibitor, and I think they're also developing long-acting injections. There's also long-acting NRTTIs that are being developed, I think, actually by both companies. So I think there's really great possibilities to have every 6-month regimens, highly effective regimens, being studied in the next few years. I'm going to skip this because I didn't really understand this. But anyway, those are the highlights for the antiretroviral therapy. Yeah, hopefully at AVRC we can try to access some of these clinical trials. We haven't really had, I think, large scale antiretroviral treatment trials or switch studies. We have artistry, but it'd be nice to build on that with some of these newer compounds as well.
Awesome. Thank you, team. Any questions? We have 4 full minutes, so feel free to ask anything, either prevention-wise or therapeutics-wise.
But mostly prevention, right?
Okay. Seems like we have no questions. Yes.
Sorry, I think I started. Yeah, I'm sorry. I started kind of midway through this. Let me just say a couple things.
Go for it.
Yeah, let me share my screen again. There was the study of long-acting CAB rilpivirine in resource-constrained studies. I thought this was like a really short deck. The CARE study. And so they presented their week 96 data, which just to say that there was great virologic suppression sustained over 2 years. What was interesting, what was a highlight from different than before, when they presented this a year ago, they said there was high rates of pre-existing NNRTI and resistance that were present at baseline. I'm not sure what exactly happened, but the rates were actually much, much lower. So there weren't large numbers of people that had pre-existing integrase or NNRTI resistance, which is different than what they had presented originally. But regardless, great virologic suppression would be a great therapy. Unfortunately, I don't think it's going to roll out at all because of rilpivirine and the cold chain, and it's really not being embraced by the WHO. Then one other thing, there was the study of treating people with advanced HIV. So that initial ART regimen for people who are presenting with advanced HIV. So in this case, they defined that as a CD4 less than 100 or presence of an opportunistic infection, basically. And they compared using an integrase versus a PI-based ART. And what they found was that basically their clinical events were relatively similar between the two groups, but the ART antiviral outcomes were better with the integrase inhibitor. So the recommendation overall was to use the integrase. In this case, they used bictegravir FTC TAF as opposed to the PI, which I think is probably what most people are doing in clinical practice, is because of the complexities of the drug-drug interactions and the tolerability of the PI-based regimen. But this does provide some clinical trial data to support that choice. I think those are just the slides I skipped over.
There's a question from Doug. Doug, go for it.
Yeah, I was about to write a note. So Tom pointed out that the high rates of pre-existing drug resistance in the CARE study was due to the fact that they looked at proviral DNA, and proviral DNA, most of it is replication incompetent, much of that attributable to APOBEC mediated mutations, and many of the INSTI and NNRTI drug resistance mutations can be created by the APOBEC restriction process. And the use of proviral DNA requires the filtering out of all APOBEC-mediated sequences. And that is done by commercial companies like Monogram, but there were quite a few posters at CROI that overinterpreted drug resistance in proviral DNA. And the ISUSA Mutations Group has written a perspective for CID, which is about to be published, that describes the cautions and the potential benefits of proviral DNA testing, but it has both sensitivity and specificity problems.
Thank you, Doug. Maybe we can try to share that CIG paper when it comes out to the group. Well, it's 9:01. Thank you very much. This was intense and very productive.
Apologies.
So, no, thank you both. I thought it worked out really well. So happy Friday and happy weekend, everybody. See you next week.
Thank you.